Okay, everyone. Hello. It's good to see everyone. Looks like there's 15 folks on now, so that's good. I would like to start by introductions. And I just hit record. Okay. So we have incredible panelists here that I'd like to introduce. Hi, everybody. How's everybody doing? Good. So I will start off with Samsara. Samsara Morgan is founder and executive at Oakland Better Foundation and Nia Healing Center for Birth and Family. And she authored Life, the Birth Plan. She's a mother of 5 sons and grandmother of 3. She's been a doula for over 40 years and has served over 1,000 births. She's the executive director and founder of Nia Healing Center and the Better Birth Foundation and Shipra's Circle Community Doula Program. She has trained Bay Area doulas for over 20 years for her own organization since 2016. She's been honored to be a trainer for SMC Full Circle Doula Birth Companion Training Program, formerly ICTC International Center for Traditional Childbearing. She has written for several publications and is the author of The Birth Plan. Her new book, Birth, A Black Woman's Guide to Surviving and Thriving, is expected to, did that come out yet or is it almost there?
No, it's gone past its due date, but it will be with us shortly.
Soon.
You're not inducing the process.
Good. I know we've talked about this before. I'm looking forward to it. Samsara serves on the board of the Pacific Family Fund, which supports reproductive choice for families wishing to birth in the Bay Area's Pacific Maternity Center. Samsara is an apprentice midwife studying under midwives Laura Perez and Judy Luce, and is student to the National School of Midwifery. Next, I'd like to talk about Miss Tora Spigger. Tora Spigner works as a labor and delivery nurse in Berkeley, California, where she has been residing for the past 21 years. She specializes in supporting patients who want less intervention and or medicated deliveries. She has been a labor doula for her private clients for 24 years. She's an adjunct professor in A&D program, teaching maternity nursing skills. She's been serving the Berkeley Health Commission for 2 years and is a member of Mothers for Mothers Postpartum, a reproductive justice and postpartum meal share program, which we will be hearing more about later. And last but definitely not least on our panelists, we have Jennifer Braddock. Jennifer Braddock is an Oakland native who has been intrigued by pregnancy and childbirth since she was 8 years old. As she matured, so did her love for the entirety of women's health. She earned a bachelor's degree in psychology from Spelman College in 1999, completed her nursing education at NYU in 2002, and her graduate study in midwifery at UCSF in 2006. She has had the privilege of serving the community as a certified nurse midwife at Alameda Health System Highland Hospital in her hometown of Oakland, California since 2008. She's currently the interim manager of midwifery services, a faculty member of the Women's Reproductive Health Equity Fellowship at Highland, and a senior community advisor board member of UCSF's Preterm Birth Initiative. Jennifer believes that her work is not merely a job, but rather a true calling. She's humbled and honored to have welcomed hundreds of babies into the world and is forever in awe of the miracle of new life and the hope it brings. Her personal and professional interests include eliminating health disparities, breastfeeding promotion, traditional healing, sacred birth practices, herbal medicine, traveling, studying ancient civilization, and of course, restoring classic cars. So I would like for us to, and me, I'm Debbie Hailu, and I work for Healthy Black Families. I'm a program coordinator for Telling Our Stories, which is a writing circle from which we publish books. Our next cohort is for pregnant women. So please follow the link and register before the day is over so that those of you who want to join the next cohort, which will be happening in the beginning weeks of May, the time hasn't been set yet. And it's an amazing experience to sit and write about our processes as moms, as Black women, and as pillars of society. So in this webinar, we also have Mama Ayana here. I almost forgot to, she is our program director at Healthy Black Families, and she does all things program related, and has been here since its inception of Healthy Black Families. So in this webinar, we will talk about what a healthy pregnancy and postpartum looks like, the current trend in inductions, not so current, right? Because it's been sort of going uphill for a while. And the very important topic of consent through process. And then we'll go to questions and answers, and then we'll close, and I will urge you to register again. Okay, so Samsara, can you start us off with talking about health and pregnancy?
Sure. Firstly, let me just say how excited I am to be here, and I'm really excited to discuss this topic. It has been keeping me up at night as a birth worker, let me tell you. And it's been keeping me up because it so violates the midwifery model of care, what's happening now in our hospitals. And I think it's so important that we're together and talking about it and hopefully getting the word out to other folks, because we're kind of trained to do what our doctors tell us to do. And we, in doing that, we lose the vital point that we are part of our healthcare team. So the team gets together, they collaborate, they huddle, they say their little chant, and then they do what they need to do. It's not one person in the team telling everybody what to do, right? So one of the goals that I have had, my vision for this time together, is that we reinvigorate the vision of the team, and we spread that out in the community so that folks remember that what their agency is, what their responsibility is, and part of their healthcare. Okay, so a healthy person who then decides to carry life inside of their body looks like this. This person is eating 3 meals a day. These 3 meals a day contain protein, whole grains, green leafy vegetables, and they're drinking plenty of water. Generally recommended 8 to 10 glasses of water for that person to be consuming on a daily basis to handle their own hydration, the clearing of waste from their body, and clearing of waste from their little infant from their body, right? That person is getting good exercise, meaning, walking, swimming. If you can do yoga and the fancy stuff, that's great, but you don't need a lot of money. You can just walk. You can ride your bike until you feel the gravity giving you trouble, and then you go back to walking. What's also contributing to good health is having a baby with a community that's very supportive, a partner, mom, dad, grandma, auntie, people, good friends who are going to be cheering you on and not telling you scary birth stories, but being really excited for you, wanting to help, offering food. If you come home from work and you're super tired, that you can just, ask, or sometimes not even have to ask, and somebody will come and put a plate in front of you with all of those components on it that I just discussed earlier, right? Skipping meals, not going to help you at all. Baby eats 24 hours a day, and the baby's in there, little Pac-Man, wanting to eat and grow and become the beautiful child that you are anticipating. And food is the fuel for the process. Food and water are the fuel for this process. There's a lot of complicated biology I can go into about it, but it's not necessary. It's common sense. Like our grandma said, girl, you're pregnant. You need to eat. She was right, right? If we're eating a balanced diet, if we're eating, as I described earlier, we're not going to be worried about weight. The body will gain the weight that it needs to grow a beautiful, healthy baby. Okay? The recommendation is around 100 grams of protein minimum for a pregnant person every day. Right? So if you break that down and you look at your day and you add in eggs and cheese, if you're a person who eats those things, even if you are, someone wrote her back till 8 months, good for you. That's to mama's comfort level. But if you're eating a balanced diet of all of those things, the body has its own beautiful genius, and it will put what it needs to put where it needs to go. So that protein is going to build your placenta. It's going to build your amniotic sac surrounding your baby. It's part of the amniotic fluid is a protein in and of itself. The baby is protein. So you're growing your baby, and you have to be kept alive through your pregnancy. All the systems of your body have to have what they need to work. Cell replacement or repair, and just dealing with being a pregnant body. Pregnancy is a stress on the body. It's a natural stress, but it's a stress. So we need to make sure that there's enough fuel coming into the beautiful engine that's running your pregnancy and keeping you alive can do that. If we do that, generally, the vast majority of pregnant people, you're going to be okay. Does that answer the question? Can't hear you, Debbie.
Yes, it does. Two things came to mind when you were speaking. One is you don't really know how you're going to feel in terms of wanting to eat, not wanting to eat, nausea, and the importance of carrying food on your person. And, having little snacks here and there. And another one is how if you don't give yourself proper nourishment, then the baby will leach nourishment off from whatever it is that you have in store, right, which happens anyway, right? Which means you want to be at the top pinnacle of your nutrition, right? When you get pregnant, but
it shouldn't happen. If adequate fuel is coming in, then the baby is getting what it needs, and it does not have to draw from the mother. So that's why the nutrition is so incredibly important.
Right.
We can make our babies a parasite. Let's not do that. We can avoid that. Right. It's my belief that, pregnancy should energize you. After having a baby, you feel like you can lift a mountain. You feel like you can be somebody's parent. Right. And so, or you're starting to feel that way, a little tired and achy afterwards, but that you're heading in that direction. So, and also this culture accepts a lot of the sicknesses of pregnancy as normal. And a lot of that can really be skipped if we enter into our pregnancies healthy, same definition, a little less protein for a non-pregnant person. But if we enter our pregnancies healthy, then a lot of the discomforts of pregnancies don't have to happen. Some things will happen no matter what you do. Be perfect, and you still will have some things. And there's even some data to show that a little morning sickness is actually a sign of a good pregnancy, a healthy, thriving pregnancy. So don't stress. But if you're eating well and you still have some nausea and whatever, then that's just one of the things that happens. But it doesn't, all of these things that happen that we say, it's pregnancy related, some of those things don't have to happen.
Yeah. So my next question is around sort of conditions people might have, pre-pregnancy, right? I have a little bit of high blood pressure, or, I'm a little bit above my, what is it called, BMI, right? Body mass index, I think it is. So, is it possible to course correct once you find out you're pregnant?
It's never too late. It's never too late to start on a healthier track. That's why I talked about good nutrition pre-pregnancy,
Right.
and trying to avoid falling into these pitfalls before you're even a pregnant person. So if we're maintaining the level of activity and diet for most of our lives, also trying to keep stress down, which is very challenging living under racism and white supremacy. I get it. And we still have this obligation. We have an obligation to stay alive. And we have an obligation to keep our babies alive. So whatever help we need to reach out for it, in getting the food and the rest and the care. If you don't have a supportive partner, do you have a best girlfriend, grandma, auntie, somebody who will curl up with you and tell you, baby, I love you, while you carry this child?
Yeah.
Doula, let's not forget doulas. They curl up and cry all the time. They love doing that.
Yeah. Anybody else want to jump in? Yeah, Jen.
Oh, yes. I just really wanted to piggyback on what Samsara is saying about how critically important it is to come into the pregnancy as healthy as possible, because like she's saying, many of these issues that we're seeing develop in pregnancy could, potentially be prevented if women were becoming pregnant in their healthiest state possible. So the importance, like she's saying, of healthy food and good food, not just food, because food to some people might mean McDonald's and Pizza Hut and soda and Doritos. Healthy food, fresh food, good produce, a lot of vegetables, home cooked meals, clean water, regular exercise, all the things she's saying. And also very important, like she's saying, is to decrease and minimize that stress. We as women of color and people of color are under so much incredible stress, and our cortisol levels are high, and our, stress hormones are always just, higher than other people. So we really have to do what we can. Like she's saying, find support, find people who love you. That just has to be a way of life. Because, I will say that, women coming into pregnancy unhealthy, with an unhealthy amount of cortisol, stress levels, toxic, emotional environments or toxic relationships, eating really unhealthy, just living on a fast food diet, no exercise. That's when you do start to see all of these pregnancy conditions that we didn't have to have in the first place. So I just wanted to echo, kind of everything she's saying and just stress the importance of that. Because I do believe we can prevent a whole lot of these pregnancy complications that we're seeing today.
Right. I think the whole idea of becoming pregnant and when you become pregnant in your life is key in this, right? Like, oftentimes people just get pregnant, it's not planned, and they want to keep the baby and they move forward like that. Oftentimes people get pregnant and they're not on the path to good health, right? It's sort of seen separate from, like, I'm ready to have a baby now, but so having to switch. And I think this is where community comes in as key, right? Like, we need to consistently talk about how we need to switch bad habits and get in a mode of, especially if we know women that we know want to get pregnant at some point, right? Like, well, it's really hard to do it once you get pregnant, so just start the move now.
I think it's very helpful to move away from like good and bad, because people have been hit over the head with that stuff. And the BMI, we want to throw that thing out the window, forget that. Generally speaking, African American women, we tend to be a bit bigger. And, for those folks who need the science, go look it up. A bigger Black woman is not unhealthy necessarily. There are other factors to be considered other than her body size, right? So I think it is about us loving ourselves as people and as Black women and as Black people, that we we punch racism in the eye and decide I'm worthy of life. I'm worthy to live. And so, and if people come at you, the people around you that speak to you, speak about your body lovingly, not be like, oh girl, your booty's too big or whatever, the stuff that we can sometimes do to each other that's just so not helpful. Right? So if we raise up our daughters and our sons to love their beautiful bodies, and one of the things that I have shared with my granddaughter since she was a very little girl is that she has in her body 50% of all of her children. She's grown up knowing that. Grown women don't know that. Right. From the day that we saw her slip into midwife Sholi's hands over at Summit when they were delivering babies there, she has had her babies, 50% of her babies sleep in her body right now. And I do see how she carries herself and the choices she's made in her 20 years of living that reflect her knowledge of that. And then they're good, healthy, loving spells that we can cast on our young ones, to help them know that they're beautiful and worthy. And if not everybody needs to be a parent, but if you feel called to be a parent, these are the steps to take. And these are the steps to just be healthy, to get your 90 years on the planet.
Period. Right. Just period. And that was my point earlier, right? Which something that Healthy Black Families does a lot is really try to infuse the knowledge in community of how important health is at all various points of our lives, right? Especially since we're constantly, bumping up against what I call white inferiority complex.
Well, yeah. And if the system wants to kill you, the most revolutionary thing you can do is refuse.
Right. Right. So I would like to talk a little about breastfeeding, to hit up the postpartum stuff also. The importance of breastfeeding, not just for baby, but also for mom, right? There's real health benefits to breastfeeding. If you guys can talk a little bit about that.
Anyone in particular wants to talk about that? Well, so I'll talk. If anybody wants to cut in, you want to say something, Jennifer?
Oh, you're on mute.
Me?
No, I was looking at Tora because she unmuted herself. So
yeah. Oh, okay.
Yeah. Well, one of the things I tell people is that, breastfeeding is I've heard these comments saying fed is best. No, fed is required. And human milk is for human babies. So if we can impress upon people that that is the optimal food for human babies, then that's what we need to do. Of course, I was a breastfeeding mother, breastfed both my children, 2 and 4 years. Yeah. They're the healthiest young people now. And I encourage my patients in the hospital and as clients, as a doula, to breastfeed as soon as possible and as often as possible. Those first few weeks is critical that they get a good breastfeeding relationship early on, because I've seen so many times where young people are not encouraged to breastfeed, they're not supported in breastfeeding, and those are the two biggest elements in successful breastfeeding: support and encouragement.
Absolutely.
Right.
Right.
And education about, we know the baby's getting enough if they're having enough wet diapers, if they are gaining weight, if they are not crying all the time, and babies do cry. So, that's one of the things we talk too about, wearing your baby when you're home, doing skin to skin, not going out partying or visiting or whatever. For the first 4 weeks, stay home, live in your pajamas, keep that baby in the bed with you and rest and recover. Because that's one of my favorite things to tell people is that, your job for the next 4 to 6 weeks is to rest and recover.
Right.
And your partner's job is to do everything else.
Right.
Or your mother or your mother-in-law or your neighbor or your friend, whoever is helping you with the baby. So that's one of the things that I really try to impress upon people, how important a good breastfeeding relationship is, and that
Right.
we have lactation support. And if you think you might have any questions or concerns, please ask. Don't just try to get through it.
Right.
Just don't ask for a bottle.
I got to relate a personal story here. I read all kinds of books when I got pregnant, right? I was ready to deliver my own baby, like walk up to Tilden with a couple of newspapers. I was ready. Like I was clear that I wasn't going to do it in a hospital. I couldn't afford a midwife. Mm-hmm. So I read up a lot. Then I gave birth, luckily at home. And then came the breastfeeding. So what I told people was that for me, and I actually think it's true for a lot of women, and there isn't much written about that. For me, breastfeeding was much harder than labor or pregnancy, right? So for me, I was dumbfounded, because then I started trying to read up on it, but I couldn't, because I was, I just gave birth and I'm dealing with this brand new being for the first time in my life. And it was intense. I have one nipple that's inverted, and I had nurses come out. It was super intense. And, we got through it. My daughter breastfed for the first year of her life. But when I tell you it was a struggle, and it's a struggle that, I had La Leche League come. I had a lot of people come to my house, tell me, keep at it. And I had a little cheerleading squad, like, you can do it. And so I think it's key. I've also read that, it's great. We can't even talk how much breastfeeding your child is good for your child, but for you, right? There's research out on like it cuts down on ovarian cancer, it cuts down on breast cancer, all these things that you don't really hear about. That's key to your health, right? Not to mention the fact, and this is how I try to pin it for my friends, like, look, y'all, you might think it's easier using this formula stuff, but it's actually pretty difficult. All the bottle sanitizing, the carrying around. I mean, your breasts are with you. It's a different ballgame.
Ready to go.
Right.
Now, along those lines, we have to talk to mamas about the medications that they use in their labor and delivery, because one of the challenges in a hospital birth, if there's how long has the baby been on one form or another of a narcotic during the labor process, and then you want this poor baby to focus and find your breast and latch on, the baby's seeing double. So or if the baby was delivered with forceps, or the baby was pulled out with a vacuum, that baby could be in physical pain. And that's something I've taught to my clients about too. Sometimes even, sometimes a baby needs to have a vacuum delivery. That is what is necessary to bring the baby into the world. But then there has to be repair work from that. Right. Sometimes mamas need medication. That is the thing to do, to help. Very often, like, the mom gets too tired, an epidural could be just a thing. She can get some sleep, and then wake up and be able to have a vaginal birth, right? But there's repair work to do after that. And so, like, if a baby has had like a vacuum delivery, I suggest things like craniosacral therapy for that baby. Very gentle adjustments, because you have a little baby and even when the baby slips out like butter, the baby could have had a issue with adjustment slithering out of mommy. So you can have a baby that had a beautiful home birth and is still having a hard time latching, or only wants to latch on one side, only favors one breast. That's a sign that it might be that one side hurts baby, right? And the baby can't tell you. It can just look at you and it can just fall asleep. That's what they do. They're uncomfortable, they fall asleep to get away from how they're feeling. They're frustrated, they're hungry, they fall asleep, right? So, knowing things kind of a bit outside of the medical paradigm that are helpful too. I do wish medical people would suggest these things too. I mean, their chiropractic is a respected mode of healthcare. It'd be great to recommend that. I think it's a sweet thing for any little newborn to have, because as I said, baby can slip out like butter and still have these little issues that can affect breastfeeding. Circumcising little boys has an impact on breastfeeding. So the baby's uncomfortable. Even if you get the hospital to use anesthetic, that's great. But then that's a wound that's healing. It takes several days for it to heal in a wet diaper because the baby's peeing, right? That's stinging for the baby's penis, and that might distract this little guy from being able to nurse. And all these things that nobody will tell you about. You're just wondering if there's something wrong with your baby or you. There's a situation. So we want to, rethink the importance of circumcision, which I personally have seen, and certainly Torah will concur that there is no value to it. There's no medical reason for it. Even in Jewish circles, there is a ceremony that can be done that doesn't involve cutting, and that also includes little girls. So it's very equitable. Both boys and girls are being welcomed into the tribe with love and respect. So let's look at that. I mean, doesn't that make sense?
Yes.
Right. So I feel like we should talk about specifically preeclampsia, because that's a real issue. Yeah. And this whole setup of getting pregnant, planning it and moving into it versus you're going about your life, you're a certain point in your life and you end up pregnant. Either way, it's easier if you can plan it right, because you know what tests you're about to get. You go in and you get the tests. There's specific stories, Samsara, you've told me about, being tested for, and testing as having high blood pressure. And I don't know how to call it, but short term. It's short term. It's what happened at that specific moment before you arrived, right, to the hospital, versus you actually have a condition. So let's talk about, number one, what preeclampsia is. If Jen, you can jump into that and speak on what that is. And then two, any one of you guys jump in and talk about how do you get yourself in a situation of talking to doctors and saying, no, I had to rush over here. This is not a good time for me to get my blood pressure tested because it's going to test as off the charts and that's going to be in my records, right? So, yeah.
So preeclampsia is a pregnancy condition that manifests with two things that we typically see: high blood pressure that's sustained, we should say, and protein in your urine, which we call proteinuria. So you have to have high blood pressure and protein in your urine to be formally diagnosed with preeclampsia. Preeclampsia is a condition that is not completely understood even today, even though it's been around a long time and it's gone through a lot of name changes. People used to call it toxemia and all these different things. But we do know that it affects different organ systems. So it affects the kidneys, it can affect the brain even, it can affect the blood flow to your baby. We think the best thought so far nowadays is that there's some kind of abnormal way that the placenta attaches to the uterus in the beginning of the pregnancy that kind of restricts blood flow. And preeclampsia is when the blood vessels kind of start to constrict and spasm a little bit. And it can cause less blood flow to vital organs. So less blood flow from the placenta to your baby, So we can see babies not grow well in moms who have preeclampsia. Less blood flow to your kidneys, which then start to release, protein. Less blood flow to your brain, which can cause women to have headaches, to the liver, et cetera, et cetera. And so I have heard stories of people not truly believing that they were diagnosed with preeclampsia appropriately. I think what's important is that many years ago, you could get a diagnosis of preeclampsia with one blood pressure that was elevated and a little urine, a little protein in your urine. That's it.
Right.
Nothing else. It didn't matter if you just ran in from the clinic from your car, you were late to your appointment, and you got hit by a bus, and then they took your blood pressure and it was really high. Oh, well, you have preeclampsia. So that definition of the high blood pressure has been changed a little bit lately to sustained high blood pressure over at least 4 hours. So at this point, you have to have, that blood pressure may be high, but if it's retaken and it comes down and it normalizes, fine. If, however, you continue to have sustained high blood pressure at least 4 hours apart, then you could be diagnosed with preeclampsia.
So I just want to say thank you so much, Jennifer, for everything you just said.
Yes.
And somebody needs to tell all the doctors what you just said. Because they are not listening to that at all.
Yeah, there's a chat here. Amy it was saying how she was diagnosed in, twice in the third trimester, and they categorized her as preeclampsia. And I know all her kids are under 8, so.
I had a client who was having a perfectly beautiful labor, and they came in talking to her in the labor. This is Kaiser Oakland, because I will tell on you. In her pregnancy, they came and started talking to her about preeclampsia because she had a high blood pressure 6 months previous. One reading 6 months previous. They happened to look back in her chart. And we were like, what? Yes, Amy saying yes, exactly.
Right. Well,
and that's happening to everybody. So like everybody, there's a mass rash of preeclampsia. Everybody's got it, and everybody needs to be induced.
Right.
Wow.
Yeah. Well, there's a big difference between hypertension of pregnancy and preeclampsia.
Yes.
Right. And then there's also a difference between just hypertension.
Mm-hmm.
Yes, ma'am.
And one blood pressure does not make any of those. Right.
And not one explained blood pressure. Like I had a client who was in a fender bender before she came into her appointment, and she told them, "Can I have a few minutes? I just was in a fender bender."
Right.
And they insisted because they wanted to get moving, and so of course her blood pressure was high, and that was constantly brought back and used against her.
Wow.
Constantly brought back. It's just out of control.
It is. And it sounds like people are not using the latest, most current evidence-based diagnostic criteria. And I would encourage people, anyone who's watching, anyone, be an advocate for yourself. You need to say, what is that? How are you diagnosing me? What 2 blood pressures 4 hours apart are you going by? Do I have any protein in my urine as well? Ask questions. What makes you think that I have this condition? Can you explain more?
Also, what lab work have you done to help rule
Thank
this
you.
out?
Thank you.
Exactly.
Lab work. Oh my God. What a concept.
Mm-hmm.
I know, yeah, we take enough blood from people when they come in labor. Okay.
And I have had clients said right to their faces by nurses, "Oh, we anticipate preeclampsia for you because you're Black. You're Black."
And this is where I think this is, when you were talking earlier, Jen, I was thinking about how if I am a doctor moving through the system doing my thing, right, and I have these ways, filters through which I see the world, I can see how it can cause me to just and not really even give information, leave alone to step back and look at it in a very specific way. So, when I hear you guys talking, what comes up for me right now is the importance of getting these kinds of informations out to our people, right? Hopefully before pregnancy, but definitely while, right? They'll tell you, and they might give you a pamphlet and tell you to read upon preeclampsia, but like the 3 different levels that you were talking about, Tora, right? And of blood pressure doing what it does inside the body, and how to navigate the system, knowing this knowledge is such an important thing, right? So
one of the most important things I think people can do as well is to, again, start your pregnancy with a healthy body pregnant, and then work with hospitals that have midwives. You know, if you can't, please do a home birth.
right.
And I'm more than willing, send me the link to your GoFundMe. I will help as many people have a baby at home as I humanly can, $20 at a time. You got that from me. That's my commitment. You send me the link, I'm gonna send you $20. And if what was gonna say? Oh my gosh, I completely forgot what I was gonna say.
It'll come back to you.
Right.
Go ahead, Tora.
Right. One of the things that I also, and which has helped with COVID, is that patients in prenatal are getting their own blood pressure cuffs and taking their blood pressure at home.
Sure.
So that is how some people can help eliminate that white coat syndrome, which is a real thing.
It's a
Yes.
very
Some
real
people
thing.
have when they
Very.
are around medical personnel, their blood pressure goes up. So get your own blood pressure cuff, take your own blood pressure at home, and do it, at the same time every day.
What
Just
type
let
of
you know what your
very
baseline is.
I'd like to know what type of education is happening as well to the providers around the responses that might happen with mothers. Can you hear me okay?
Mhm.
Everyone, just checking. Because there is the white coat syndrome, and there is also our understanding that most often when we enter these institutions, we are going to, we might not call it this name, but we are going to run into institutional racism, right?
Absolutely.
So that automatically brings your blood pressure up. There's a level of toxic stress that is intergenerational now. And then as Jennifer spoke about the cortisol, right? We know that is the undercurring hormone of toxic stress.
Absolutely.
And that it will automatically raise your blood
Right.
pressure with a mild trigger. It doesn't even have to be a major trigger.
It's true.
And so that has to be incorporated into how we educate our birth practitioners and birth providers, as well as along with toward the cuff, right? The blood pressure cuff, actually providing education along, a talking sheet, talking points along with the blood pressure cuffs, and then the education around how do you advocate for yourself, right? Because that's the other thing. I think it's extremely important that our moms know that they have a right to refuse certain levels of treatment, and then know the symptoms when they're really in trouble, and then the symptoms that are being used to create these inductions and C-sections unnecessarily.
Right.
That's why I really recommend working with nurse midwives or home birth midwives, because they will have that natural state of mind. Not all of it. There's some nurse midwives I want to talk to, but for overall, their training is more about, prevention and physiological labor and delivery. And so but you have to not be in a high risk category. If you are in any kind of high risk category, you're with the docs and that's it. Right?
Right.
So that's why I got back to, I remembered what I was going to say, how we want to start healthy in pregnancy and work with a midwife who will support you and coach you in staying healthy.
Exactly.
And I wanted to add 2 things to that. I think, Mama Ayana, your point of, when we walk into a building where we're supposed to be receiving health care, and it's supposed to be about wellness and taking care of us and our baby and our pregnancy, but our cortisol goes up and we get nervous because we're there, that's an indicator that that's not a peaceful place. Like, that's not a place of healing. That's not a place of healing then. If it causes you innate stress and you have this sort of fear, right? I think this is a huge plug for home birth or just out of hospital birth. It could be at a birth center for anyone who is low to medium risk, who can give birth outside of the hospital in an environment that's welcoming and caring and supportive and honors you and celebrates you, and you walk in and you feel loved, your blood pressure is not going to spike up like that. So that's the first point, is that that's just so important, kind of, which just speaks to, you know, these clinics and these hospitals aren't built and designed to be places of wellness and calm and peace. Let me give you an example, actually. Me too. I had white coat syndrome. I'm a healthcare provider, and they make me nervous. So I understand. And then the second point is that while I do think some people are using very outdated diagnostic criteria for preeclampsia, preeclampsia in and of itself is a real thing. So just as a midwife, let me just say, like, if you have preeclampsia, and particularly severe preeclampsia, like, that's very serious. So I don't want anybody blowing off, you know, any medical treatment if they do have it. But obviously the point we're making here is that it needs to be diagnosed appropriately and correctly.
Exactly.
I agree with that. The other thing you brought up, Jennifer, that I think is extremely important is you brought up the environment for our mothers and our families. And I know that you can, if I'm rushing and I'm a little late, or, you know, someone sideswiped my car, or whatever happened, right? If I have a moment to calm myself and a space where I feel supported, my blood pressure is naturally going to start lowering itself. But if I'm going into another stressful environment, it's going to hold. Right. So we have to also look at the environment that we're creating for moms, and the idea of having our own birth centers, right? And our own spaces. We have to begin to also advocate for that. We have enough in our society to support births in this way that can create, or really nice birth areas and birth rooms and examining rooms in the institutions that our governments are supporting.
I mean, you know, there's so many administrators' offices, and they look kind of nice. So, you know, why can't we have, you know, and if you look at birthing areas in maternity hospitals in Europe, they look like birthing centers. They're warm and they're rich colors, and there's tapestries on the wall, and there's a birthing tub in every space. And I mean, you know, why did Kaiser Oakland put up that whole hospital with not one bathtub in labor and delivery? Not one.
You know?
And then they advertise hydrotherapy on their website.
Wow.
They advertise hydrotherapy on the website. Like, where's the hydrotherapy? I'd like to know. Oh, here's the snozzle that you can shoot at your belly, the water from the shower. Or
you can go take a shower.
Right. Well, that's one of the things that I try to address with, I work the night shift in at Berkeley Alta Bates. And when I get a patient, when I sit in my room, it's dark. I have the booty videos playing with the soft music. So you can feel the palpable energy when the patient walks in the room, and I close the door behind them, and then they're like, this is so much nicer than triage or the hallway or wherever they were, you know, before. And it just helps bring down the energy in the room.
Yes.
I make a conscious effort.
Clone you, Tora.
Like, I walk into a room where another nurse has set it up and all the lights are on, and I'm like, no. This is not okay. So, yeah.
Environment.
I also teach my new nurses this.
Yeah, that's amazing. That's amazing.
Happy you're training nurses. I'm so happy that you're training nurses. Really, thank you, thank you.
And the environment is so important. I mean, birth
Yeah.
is, you know, a primal process. It's physiologic, it's natural, but there's certain elements that help move it along better and easier, right? And
Right.
so dim lights and calm and peace and, you know, an atmosphere that's soothing and supportive will help labor unfold, you know, hopefully easier and better and
Right.
calmer.
I mean, it's
Exactly.
muscle contraction, right? Like it's
Yeah.
muscle contraction. And if you're
Yes.
tense,
Well, it's the release of oxytocin that causes the
Right.
muscle contraction.
That's right.
Exactly.
So can the couple
Samsara.
snuggle up in bed together and have a few kisses,
Right.
you know, and get in the shower and snuggle with each other and make that oxytocin and get that labor going? I mean, that with some orgasms will work.
Yes.
If you're in a place, you know,
Right.
if you're in a place, how can you do that with people just open the door, they don't knock before they come in,
Right.
you know, it's these little things that just mean so much biologically and physiologically.
I agree.
It's about respect.
Debbie, I just wanted to ask you.
yeah, are you talking about what I think
Yes,
you're going to talk
please.
about? I got
Yes.
that. But I want to move, I want to, first of all, Lisa is in our group and I want to introduce her briefly and then bring her up as a panelist while she's on the go. Hey, Lisa. Can you hear us?
I see her.
Yeah, she came in. So Lisa is a certified nurse midwife working in the Bay Area and has been doing this for a minute also. She was supposed to be on this panel, but a family emergency came up. So preeclampsia is something that plagues us, right? At a much higher rate than other women, right?
Mhm.
It's really important that we read about it and talk about it. And you know, that segues into all different kinds of interventions, right? Hey.
Hey.
Hi,
Mask.
Lisa.
Hi.
Good to see
Yeah,
you.
good to see you guys too. I was listening in. I didn't think I was going to be on. Sorry, I had a death in the family and I'm on my way to Atlanta. So I'm just about to board. So I can speak really briefly and then I'm going to get on the plane.
Yeah, feel free to hop off whenever you need to.
Okay. So, you know, wherever you guys were talking.
We were just about to pivot into inductions. We were talking about, we talked about health and during pregnancy and postpartum. And we talked about, we were touching up on preeclampsia and wrapping that up and then moving into inductions.
Okay.
I think it's also, before we completely pivot, it's important to mention that folks can have issues with high blood pressure in postpartum as well. That is a thing. So you want to be cautious about spiking blood pressures after the baby is born, headaches, blurred vision, anything else I'm leaving out, please feel free to add in. But if you're not feeling right after you have the baby, don't wait it out. Get checked, rule it out medically, you know, and then there's things like acupuncture and other things you can do, but I would check it out medically first.
Wow, I didn't know that. That's important to know.
Postpartum
Yeah.
preeclampsia is a thing.
Wow, okay. Yeah,
Okay, so I'm just gonna, can I just, as you talk about inductions, I'm gonna say, it's not gonna make sense to a lot of people because it's kind of out of order, but I'm gonna say this quickly because I have to get on the plane.
do it.
They're gonna talk, Samsara's gonna talk a lot about inductions and how the hospitals are increasing, you know, our induction rate, and a lot of it had to do with COVID. It wasn't really scientifically based and all of that. And she will talk about reasons to have an induction and reasons not to. And really, I am coming from a perspective of being a home birth midwife, where we want to do as little intervention as possible in a home birth setting. But as the state has set up a lot of rules that dictate what midwives in the home setting do, we do have what we call an encouragement of labor process, because the state says that we can't have people in the home birth setting greater than 42 weeks.
Right.
And so simply because of that rule, not really because of anything else, plant medicine is the, we have everything we need in plants, and herbs and natural medicines to encourage labor. And so that's something we specialize in. We know how to get labor going. We know how to control labor. We know how to, to get things going, and we use certain herbs and concoctions and certain methods like breast pump stimulation to encourage the labor. And sometimes we're weighing our risk versus benefits. If there's nothing really wrong with the baby's been fine, the pregnancy is healthy, there's no reason why she can't really have a home birth, except for the fact that she might be 42 weeks in a day and the state says she can't have a home birth. And so I'm just gonna, so that's our induction method. And but in the home birth setting, we highly recommend as little intervention as possible, because that's when we see the best outcomes, when you have little intervention.
Exactly.
Okay, I'm gonna say that, and I'm gonna say blessings to all of you. I have to get going.
Thank you, Lisa.
Thank you, Lisa.
Thank you for having me.
Bye, Lisa.
Yes,
Much
ma'am.
love.
Bye.
Sorry for your loss.
Oh,
Yeah.
that's really true. I mean, we have to look again how patriarchy and white supremacy are bearing down on our pregnant ladies and our pregnant people. That arbitrary rule that, again, we're not going to trust the midwife to know her client. The midwife's been taking care of this person. They know if somebody's having an issue with going beyond 42 weeks. I'm very fortunate that I've been a doula a long time, and I've worked with midwives a long time. So I got to see a lot of stuff that the younger doulas might not get to see. And seeing people delivering babies at 43 weeks at home before they change the law. And everybody's healthy and beautiful. That midwife's doing her job. She's checking daily. The NST is the midwife coming to the house every day and checking on that family. That's the midwife with her ears and, and knowing that baby and knowing what's healthy for that particular mama, because we're not cookie cutters. Everybody's different. What might be healthy for me might not be healthy for the next lady sitting next to me. And the midwife is the one who knows the difference, because she has that personal relationship, and midwifery visits are an hour is a short midwife visit. We were actually there in the office and talking to the midwife and weighing you, and I had a fight with my mother, and she's doing all that beautiful psychosocial stuff that keeps your blood pressure down, because you just had a fight with your mom and you're upset, and you go to your midwife and you talk it through, and she says, let's have your mom come in next time, and then the midwife's doing family therapy. So that's what's needed sometimes to keep things growing and smooth. And then everybody loves the midwife because she cared about everybody, even the rapscallion of a mama. So bring her in line so she can be helpful to her daughter.
And we're behind. I mean, I think England, right? I mean, there's do you guys know what other countries are where midwives are an integral part of women giving birth?
Everywhere but here.
In the systems, right?
Every industrialized country but here.
Yeah, that's
because here we want to make money.
Yeah, and they have much better outcomes.
Much better.
We pay the most, like our healthcare costs the most. Like it's the most expensive healthcare system. We pour so much intervention and medication and artificial things at it, and we have the worst outcomes of all these other developed.
Makes sense. I see the intersection right there. Yeah, makes perfect sense.
It's so frustrating how we're talking two different languages. Like doulas and midwives are saying, and the world at large is getting to, these disparities are leading towards more Black women dying, more women overall dying. This is not a safe country for any woman to give birth in. If you look at the numbers, it's pretty scary. So what the doctors do is say, we'll just keep throwing more medicine at it.
Right.
When the cure is to pull back.
That's right. Right.
Right.
Right, yeah,
We're doing
I
way
was-
too much.
We
yeah.
have to create a cultural shift here. When you're talking about this, we're talking about a whole culture that has become toxic, right? We did have a really great culture of midwives anchored by Black midwives and our teachings. And then it got taken over by allopathic medicine. And now, after what, 100+ years, we're looking at it and we know that it doesn't work, right? And
Right.
it's clear there are statistics and numbers and research that shows this. And so part of what we do as Black people in the United States is create culture. So we have to have a specific intention of changing and creating culture. And this means that we have to create a mass education campaign
Right.
centering around this.
Yeah,
Yes.
I'm curious about, how do I say this? So in my circle of friends, smart, beautiful Black women in the Bay Area, women I consider brilliant were not considering home births at all. And I'm talking about people 5 to 10 years younger than me, right? So we're hitting the 30-year range now in their 40s. I'm talking about when they were in their 30s. And I'm just going back to your point about shifting culture, Ayana, because it's not that these women were not smart. It's not that they didn't have access to knowledge. There's this belief still, there was at least about 10 years ago. And I think most of them have changed their tunes because now that they're on their second and third babies and have actually gone through it, right? But when they first go in, there's this sort of like, oh no, of course I want a doctor to handle this. Birth is still fear. There's fear around it. And, we live in a great Bay Area. So I think there's a spectacular bubble, not wide enough. And we definitely need to grow it out. But, and there's bubbles across, Brooklyn and other places that Black women are growing. But I just wanted to piggyback off of that, Ayana, the whole cultural shift thing.
Well,
Victoria, you were going to say something?
Yeah, because, well, you realize that because of our healthcare system, midwifery there's not enough midwives. There's not enough experience with midwives. So people don't realize, I still get questions, what's a midwife? What's a doula?
In Berkeley.
But people know what a doctor is.
right.
And that's one of the things that people, especially after they have their first baby, and then they're like, that experience was not how I thought it would be.
Or it was hell.
Right. That's when they find there must be something better. There must be something. One of the things when I had my children at CPMC in San Francisco, they didn't have midwives. So I chose an obstetrician with years of experience who was not dictated by his ego, but he was intelligent and he was supportive. And he said to me, the sign of a good obstetrician is one who knows how to sit on his hands. Yes.
Where did that go? Where did that go? I mean,
He retired.
Yeah, exactly.
He was, yeah.
And
I
thinking
said in your former life, you were a midwife with 5 kids.
Wow.
Yeah.
Yeah.
This is remembering the doctor who delivered my twins. I had twins when I was 19 years old. And it took a lot to find him, but may he rest in peace, Dr. Klein in Brooklyn. And he was a lovely fellow. And his whole attitude was like, oh, you're so young and you're so healthy. We're going to have a good time. This is going to be fun. Now imagine if your doctor says that to you. Would I have high blood pressure come into him?
Right.
Anything? He was just so loving. And he was just like, he would come and greet me when I came to his office. He would come out of where he was and go, oh, you're here. Hi, how are you? How are the kids? You know, and I'd be like, I love this man. I would do anything for him. Where did those gentlemen go? And where ladies go? Because even ladies are not loving up their clients like that. Because we had this big dream that, oh, you know, once women of color started to, there's not enough women of color, but the few that there are at, they ain't loving their clients up like that. And of course, there are a few who do, not, you know.
Right.
But I'm saying there's not enough.
Right.
Right.
Well, you realize that they're getting the same training as men, and historically white men, and they're not going into OB for the love of it. They're going into it for the money. And, you know, I work with several OBs that I would not let my dog go to.
You know?
So,
You know?
and people ask me all the time, who do you recommend for my care? And, you know, I have some favorites. People who treat women with respect and who are about education, and they do their baby catching with love and respect. They're few and far between them.
Yes.
Sweet.
Oh,
They are.
yes.
Yeah.
They are.
Yeah, Tora, I really hope you're passing this client advocacy to the people, to the nurses you're training. And I really hope they're able to embody it.
Right.
I mean, to, you know, a rice grain size that you have, because that, you know, that will.
Oh, yeah. That's a big part of my teaching of my nursing students. We talk a lot about advocacy and questioning things, because just because this is how they've always done it, what you ask why do we do it that way? And sometimes just questioning it will cause a change. And it takes a minute for things to change, but we're doing better. We're doing more skin to skin. We're doing more delayed cord clamping. It's taken years, but it is happening. We don't give baby baths anymore.
Thank
I mean, little things like that really help the bonding process for new parents. The golden hour. Try not to do things to them in the first hour of birth. You know, leave them alone.
Poke,
I had a
prod,
new ALS nurse.
Right.
I had a new ALS nurse the other night take my baby after it was like 3 minutes old. I was like, "Where are you going?"
Oh, no.
Mhm.
I'll train her. Don't worry.
Yeah,
I'm sure you will. I'm sure you will.
Get her together, Tora.
So what are some of the questions that moms and family support and advocates should be asking in situations like that? For example, is this necessary about things? What are you as birth workers, what can you tell us and what questions should be brought forward in situations where they're telling you your baby looks too small and we need to induce, or you know, your blood pressure went up suddenly when you came to the office and we need to induce, right? Are there questions about tests? Are there questions about procedures that we need to begin to teach our young mom, not just young, because there's older moms that are also at high risk as well.
And
Well,
the
one
younger
of the things
one.
I think Sarah was going to touch on the reasons why people are given for induction.
Mm-hmm.
Right. I would like to pivot to that conversation.
Yes.
And then we can talk about the process of making informed choices.
Consent. Right.
Okay.
Well, one of the things that everybody who is registered for this workshop is going to get is a beautiful document that was created by Jessalyn Valorano, who's a communication director for Oakland Better Foundation. She's a genius person. I just say to her, this is what I want to see, make it come true. And she just squints her beautiful brow and creates stuff. And so we have this beautiful document now that talks about medical reasons for induction. It talks about what is health. It talks about the ARRIVE study, which is a really problematic study that doctors are using as a reason to say that going beyond 39 weeks is not necessary anymore in pregnancy. I had actually had a doctor say to one of my clients just 3 weeks ago, there's no medical reason for a pregnancy to go on beyond 39 weeks. There's no medical benefit to that. Okay.
Could you say that again, Sarah? I want to really.
The doctor told my client that there is no medical benefit to carrying a child beyond 39 weeks.
Wow.
Right? Wow.
Yeah, that should blow everybody's mind.
Well, I also want to contextualize that this is happening in
Right now.
our Bay Area bubble, right?
Right
Like
now.
that's what's key. Like
We need
we
to
have a
lose
lot of
the
work
Bay
to do.
Area-
Yeah.
We need to lose the Bay Area bubble thing. I've been practicing here a long time. There's no woo-woo stuff going on. There's no, I mean, there are places that are worse. My beloved hometown of New York is pretty bad. And so we're better than them. But what's happening here is hideous. Just 2 weeks ago, one of my clients was told by her physician, pregnancy is a disease. The cure for the disease is to have the baby. That's just 2 weeks ago.
Wow.
UCSF.
And see, if that is your perspective on pregnancy and
Right.
childbirth and labor and just the spirituality of giving birth and carrying a child, you do not need to be in this field. You need to be a surgeon, or you need to go into, something where you can have that kind of mindset that it's pathology.
Right.
But pregnancy is not illness. It is not a disease. It is not, and so that's where we have to start first. Like if your provider, midwife, doctor, whoever, believes that your pregnancy is an illness or a sickness that you needed to be rid from or, saved from, you need to find
Baby's like a tumor that needs to be removed from your body for you to
That
be.
is outrageous.
That is outrageous. That's unconscionable.
And it's dangerous.
It is.
Client calls me in tears after that doctor's appointment, and I'm talking her through how, that is so not accurate. There's no science in what you were just told.
Right.
There's no science in that whatsoever.
There was no love in that.
And there's no love in that.
None.
Yeah, right. Somebody who's not.
She was strong. And some people are in this job trying to have power over others, male and female obstetricians are guilty of this.
Yes.
And it's about controlling other people's bodies and what they do. It's
Right.
not about honoring the Hippocratic oath that they're supposed to take. Do they still take that? Because I don't know.
And it's also about capitalism, as you brought up.
Oh,
with
so much
Right.
about
They
capitalism.
make
Yeah.
excuses to bring in these procedures, often unnecessary, so
Right.
that they can then increase the charges and make more money off of these births. And if they see you have whatever level of insurance, because we also know that there's a history of mischarging with Medi-Cal, right?
Absolutely.
And what I consider scamming Medi-Cal through the birthing industry. So when we talk about capitalism and its place, and then patriarchy and its place in this process, right?
Yeah.
Or in this industry, as they would call it, then we have to look at what are the motivators to dehumanize birth and our babies in our womb and our mothers in this sacred process part. I mean, it's just so sacred. It's just the most sacred and beautiful thing we could do on the planet.
Right.
Yeah.
It really is. And it is, like you said, it's for reasons of capitalism, control. There's no
Power.
reason why, control, exactly. And for sure. And convenience many times, right? It's just convenience.
It's like during COVID, it was about, the excuse was, we want to know how many people are going to be in the hospital at any given time.
Right.
And so we want to induce everybody so that everybody's got their appointments and they could come in all nice and orderly for us to take care of them. And then they were saying was about to reducing your time in the hospital. But an induction takes several days.
It does.
Right.
A what? What takes several days?
An induction can
Oh,
take several
Jennifer,
days.
what is an induction?
So an induction is when your labor is artificially and medically started. So your labor does not begin spontaneously. Your body doesn't go into labor naturally. It is when by, synthetic artificial means, medication, pills, whatever, your labor is artificially started. So basically we are trying to force your body to go into labor when your body and your baby aren't ready yet. And that can be for a genuine medical reason that you should be induced, or like we're talking about now, many times it's an unnecessary induction. And whenever we force your body to try to go into labor when your baby and your body are not ready, there are risks associated with that process.
Absolutely.
Can you guys hit on the different types of inductions?
Yes. Yeah, I can tell you there are 4 kinds of induction that we do. One is Pitocin, which is the synthetic oxytocin. It is not the same. I've seen people use it interchangeably. It is not the same.
Not the same.
Oxytocin, that means that the patient has to have an IV. That means that the patient has to be monitored continually. That means that the patient sometimes can't or won't be allowed to eat or move around as much as they want to. The second most common form of induction is a medication called misoprostol or Cervidil. And those are both prostaglandins that are inserted either into the vagina or taken orally, or those are the most common ways that are given to start thinning out the cervix and causing contractions.
You want to talk
Both
about
of those,
Foley also. The
both
Foley.
of those cannot be used with patients who've had a prior cesarean section. Okay. The third method is becoming more and more popular, is called a Cook's balloon or a Foley catheter. And it's a tube that's put into the uterus through the cervix, and it's filled with sterile water, usually 60 to 80 cc's. And then more sterile water is put into the tube that's in the vagina.
Wait, what is 60 to 80 cc's? A pint? Like, what is that in
What does that look like?
yeah.
I don't know.
That's
How
good.
much is that? How many ounces is that?
That
Somebody
much?
has to look that up. I don't know.
I'll look it up.
I've
I'll
never,
look it up
yeah.
now.
Okay.
But so basically it causes pressure inside the cervix. So it's a mechanical way of making the cervix open.
Okay.
So once that pressure is makes the cervix open artificially, then it comes out. And then, but our protocol is that after 12 hours, it should be removed because it can cause issues with the baby, things like that. And the fourth way that we induce labor is sometimes breaking people's bag of water. So then you have the process of you have removed the barrier, helping protect the baby from infection. And then you're put on a time limit.
Right.
How long it can be before you either develop an infection or have a baby, either vaginally or by cesarean section. And the other thing we need to impress upon people is that when you're induced, you're 50% more likely to have a cesarean section.
Absolutely.
Wait, I didn't say that again.
You're 50% more likely to have a cesarean section, whether necessary or not.
So this is key, right? Like you got to go into it knowing that. And I'm just curious, like in the hospital, is that given to them?
Yes.
As a fact?
They sign a consent form that talks about the methods of induction. And then they need to also be aware of augmentation, which is you've gone into labor on your own, but the provider feels that your labor is not going fast enough or that it's stalled. And sometimes it stalls for valid reasons.
Right.
Your body is hungry, you're tired,
Tired.
blah, blah. So then those methods are used to help your labor along. So the people need to be aware that there's a difference between induction and augmentation. And that, you increase your risk of having some kind, it becomes a cascade of interventions, because I don't care what anybody says, Pitocin contractions are stronger than regular contractions
That's true.
because your body doesn't get to build up the endorphins to tolerate the contractions because they just go from 0 to 100.
Yeah.
Okay.
And I read something about the thinning of the lining is a process that can be preempted by
The thinning
The
of the
induction.
cervix.
cervix.
Right.
And so then it preempts
Right.
then
Right.
it never really thins to this
Right,
place
right,
where it needs
right,
to,
yeah.
and you're stuck.
Right. So no, there's something called a Bishop score, and that's used medically to evaluate whether a person has a favorable cervix for induction. And if your Bishop score is less than 8, you should not be induced. And that means that your cervix is thin or thinning. It means that your baby is not high, is not up in your tonsils somewhere. It means that you're, that there's all these criteria that have to be met. Mainly it's the
being
thinning of the
eliminated.
cervix. If your cervix is, 20% effaced, that's not very favorable for it opening up and letting a baby out.
The Bishop score is being like eliminated. Like no one's even caring anymore. They do not care.
They should
do
care.
not check.
because-
I know they should, but they don't.
Right.
They're like,
See, but patients and clients don't know about the Bishop score.
right.
So that's something that they can ask the provider before they are induced. So what is my Bishop score? And they're like, oh,
Absolutely.
where did this person hear about this? They've been on the internet learning stuff. Right.
Thank God.
And then the doctor tells them, don't go to Dr. Google.
Mhm.
Right.
Right.
Don't use Dr. Google. And I'm like, well, how do we get to check your butt then if we don't
Right,
go to
exactly.
Dr. Google?
Right.
And I can tell you my 2 biggest pet peeves for inductions are, well, there's 3. There's the elective induction. And sometimes that's valid if like your care provider is in town, like your mother is in town, has to leave. That may be, and they need to take care of your older children or whatever. I mean, that can be a factor. Come on.
It can be a factor, but if you
It
get
can be a factor.
infected, you ain't
Right.
gonna be taking care of those kids. So
But and the AMA inductions, oh my God, that just irritates me.
What is that?
Advanced maternal age. So
Right.
somebody's being induced just because they're over 35.
And that's new. That wasn't happening when I first was in practice. That's in
no.
the last few years that's
I'm like,
come up now.
if
It's
the person
that
can
because-
get pregnant and maintain the pregnancy, what makes you think that once she's 37, that baby's not going to come out?
It's so arbitrary, just a random age. They've just decided, okay.
Right.
I know. I had
Right.
babies at 38 and 39. My grandmother had my mother at 43, and her mother had her at,
Wow.
my great grandmother had my grandmother at
Right.
47. My niece just
Wow.
had a baby at 46. So when you're talking about where they're looking at where you're at risk, and I was a very healthy 37, 38, 39-year-old woman, right? Who
Right.
looked much younger than her years, and my body was acting much younger.
Right.
And there was this constant trying to make me fearful of being
Right.
an older mother, right? And I'm like,
Right.
I don't think so. In my family, women have babies
Right.
will be having babies for 10 more years.
Right.
So
Right.
I feel very comfortable with this and having a natural birth. But you brought up something for me that I didn't realize. My wonderful gynecologist or family doctor, she wasn't just an OBGYN, did at one of my burst, I think 2 of them out of my 6, I'm the birth mother of 6. 2 of them, she burst my bag open, right? And I never thought of that as an induction. I wasn't, I didn't really think it should happen, but we were like, she said, well, you're 8 centimeters, or you should, but the baby's not coming where it should be, so we're gonna help it along, and we're gonna burst the bag, and of course, in retrospect, and I was already a birth worker by that time, not the first one though, but in retrospect, I'm thinking, so it became easier for her, respectfully to her,
Right.
but it became easier for her to burst my water to make the birth easier for her. I don't know if it was easier for me or not. I really can't
Right.
remember, but I do know that 2 of my bursts, it was like, okay, the baby's not along far enough. You're dilated further than the baby is along. So what do we do in situations like that where we're having a perfectly normal, healthy birth, and you have someone want to induce by
You just say no.
bursting your back? Just say no.
You say
Right.
no. Do not
Right.
break my water. I do not
Right.
want my water broken.
I do not
Okay.
consent to having my water broken.
I do not consent. That's as clear as
Consent.
well. And hopefully there's a doula there to hold that mama's hand so she can say that,
Right.
and
Or
then
a
get her
nurse.
up and walk her around and get her in the shower so she
Right.
can finish having her baby.
Or a birth advocate, and at least someone there that is actually advocating for the type of birth that she wants, and has
Absolutely.
Right.
these things in writing or on their phone, that's how,
Right.
or their tablet.
Or as the nurse, I will say to the patient, you have the right to refuse anything.
Mhm.
And I remind them of that.
And then how do we let our nurses know, right, or who's ever, if we're in the hospital,
Mhm.
right, that are the people that are attending our birth know
Right.
what our needs are.
Well, having a birth plan is an excellent idea, like Samsara's book.
Yes.
But talking to your nurse about your expectations in labor, because we're supposed to ask you that. And then sometimes when the physician is in the room and wants to do things, I will say the patient has indicated that she does not want this, this, or this.
Mhm.
And the patient hopefully will speak up and say, oh yeah, that's right. And I make sure that everybody gets a copy of the birth plan when they walk in the room.
That's
And
good
I was-
nursing. That's wonderful nursing, that we want to see more of that. I keep coming back to that because it's really, it's like a
Yes.
drop of water in the desert. That's not happening everywhere at
Right,
all.
it's
I'm
not.
Oh, no.
I'm blessed to have a very busy doula practice, so I see it.
Yeah.
It's not happening the way Tora explained.
Right, it's not. And also to your earlier question, what questions can you ask?
Yes.
Mariana, I think you can always ask, what's an alternative? Okay, why are you recommending this?
Right.
What are the risks of that?
Right.
Explain to me all of the risks.
Yeah.
And what is an alternative? Because many times something will be recommended, a certain course of action, or you need to be induced tomorrow, or we need to do this. What's an alternative? Because it could be something as simple as, well, can I just come in tomorrow and have my baby checked and we wait and see, that might be a simple alternative. Well, can we wait for a little while? I'll get up, get in the shower, walk around, and we'll see how I'm progressing in a couple hours. It's not usually, unless it's some severe emergency situation, nothing has to happen right away. There is time. There are many other things that can be done. It's not just one course of action. So be empowered to ask, what else, what other things can we try or can we do?
Yeah. Let's,
Yeah.
Tora is going to talk about all of this stuff, but I kind of want to revisit this due date notion as we discuss inductions,
Right.
and kind of peel back the layers of
Right.
due dates a little bit. I know that these very brilliant women that I was telling you about were hell-bent on making sure that they have their babies on that day, because that was the energy that was transferred to them through their doctors and their prenatal visits, right? So which is funny because, we're African and we don't do anything on time, really. I mean, it's, and I'm like, really? This is where you're going to put down your gauntlet? Okay.
Right.
So can we talk a little bit about the whole notion of due dates and the difference between how midwives at home give it versus the way doctors give it? And there's some evolution to that, right? There's a trend and evolution of it getting less and less. So
there's a lot of evolution. Like 100 years ago, if you were having a baby, they say sometime in March.
Great.
Your baby's coming sometime in March.
right.
And it would be the woman that would tell the doctor that.
Right.
Not the doctor telling the woman that. The woman's in her body. The woman knows who she had sex with. The woman knows when her last period was. And the doctor would be, and she'd say to the doctor, gee, I think my baby's, or the midwife, I think this is a spring baby. And she'd go, okay. And we'll measure and do our thing. And actually, the further back you go, the less interventions that home birth midwives would do. They weren't poking and prodding and sticking their fingers up in there. As they were pushed to be more professional, they started to do that stuff. Granny midwives didn't put their fingers up inside their clients.
Right. Yeah.
And they were able to monitor those pregnancies quite well, thank you.
Right. And 40 weeks is considered a term pregnancy. Okay. So I've seen inductions for post dates at 40 days, 40 weeks and 3 days. I'm like, that is not post dates. According to the obstetricians and gynecology, AWAN is not according to ACOG, the American College of Obstetricians and Gynecologists. So, but people are using that to get people to come in for induction. Oh, your baby was due 3 days ago. So
Babies do when it was
baby out. Right. And their cervix is like definitely not ready. Yeah.
And there's important information that I'm forgetting the study that shows that there's a high probability that there's a hormone that's released from the baby's lungs when it's ready to breathe. And that starts the labor.
Yeah.
This is important.
What we're doing to these children, rushing them out of their mother's bodies 2 weeks before they would have come on their own.
Right.
And I, as a mother of 6 and a doula, one of the things that I began to really understand and work with my mamas with is the idea of when you ovulate, right? And being able to track your ovulation. It's not just from your period, right? Or your last period. There's a period in there of ovulation and actually kind of talking the mamas through, what that feels like when you ovulate. So you can have a better understanding of when conception happened, right? And a more intuitive sense of when you're going to have the baby, right? And so that often I found OBGYNs were really off. They're like often 2 weeks off because whatever, I mean, really consistently 2 weeks off or more in determining when the baby should, and usually when I'm saying it's like 2 weeks ahead, so they're saying, well, your baby, you should be 39 weeks. And I'm like, no, I think I'm probably closer to 37 based on, and they'll be
your own calculation.
Yeah, my own calculations. And then having to, I had a doctor that trusted me, right? And she was a Black woman, right? And she trusted me, and I was able to interact with her in a way where she also respected the level of education and experience I had. And then having had that experience, I was able to bring that to practicing, or being present as a doula with community and family. Right. But so often there is this lack of trust that is put toward women or put on women about their bodies and the understanding of their bodies and being in communication with their bodies and their baby. I remember wondering if one of my babies was I just like, is this a boy or a girl? And it was further, and that baby sent me a dream. And literally in that dream, let me telescope onto its penis, right? You know, so I mean, and I know we have these experiences, but there's a sense of not trusting.
No room for intuition or spirituality or
Right.
ancestors in the process
Not
at
at
all.
all. Not at all.
That is not science-based.
No,
Right.
not in the medical model. No, absolutely
Not at
not.
all. No. Yeah, it was my first.
Midwives and doulas and nurses, you
Right.
and you all understand that there's, and you have an more African-centered point of view that
Right.
allows for spirit and internal communication and physiological understanding outside of so-called Western science, but in the science of knowing your body, right?
Exactly.
And the science of communication with
And
that.
respecting that baby as a living being
Mhm.
that has a way to communicate. I mean, I've had my clients' babies wake me up out of my sleep.
Mhm.
Like,
Yeah.
hey, Miss Doula.
Yeah.
Yeah,
It's time.
I have two.
We're not seeing you for 3 weeks. Why are you waking me up?
Right.
You know, and that just a respect for that part of life too. There's a right and left brain.
Mhm.
There's the heart and the brain. They work together.
Right.
I have babies communicating with me right now, telling me they're coming.
Mhm.
Yeah.
You know,
And I will trust that.
Oh yeah, totally. And I trust patients when they tell me things
Right.
like there's something wrong
Mhm.
or the baby's coming right now.
Mhm.
And I've had physicians say, "Oh, I just checked her 20 minutes ago and she was like 5 centimeters." I'm like,
That's
well,
my favorite.
I'm gonna believe her and I'm gonna get this room ready for a delivery. And inevitably, patient says, "Oh, you know, oh," and the baby comes out.
Mhm.
Hello. And this thing about swearing that somebody's not in labor if she's not howling like a banshee.
Right.
Now, some mamas need to howl. I'm not shaming howling.
No,
Howling can be crazy, helpful
Yes.
in labor.
Mhm.
But some mamas are quiet as little monks and they're 10 centimeters.
Yes.
Great.
Yes.
Yes.
And so you can't go, oh, you're not, again, a doctor said, I can give you all the quotes during this talk. You're not suffering enough.
Oh,
I want to add, when we talk about consent, because we haven't gotten there, but I really do want to talk about consent and what that means.
Yeah,
in the
definitely.
process.
That's a big part of all of this.
Yeah.
But I mean, did we hit everything we need to hit on?
I want
you
to
guys
go
doing?
back just really briefly and
Okay.
pick up and just give some information on the drug Cytotec and misoprostol. Those two are the
Good,
same drug,
good.
and they're very problematic. Their history is very problematic. Like with all medicine, I'm sure the medical folks will check me on this. Please feel free to do so. There's a time and a place for everything. And this drug has been linked to a lot of issues for moms and babes. So you want to see if maybe something else, say Cervidil or other cervical ripening agent might be available. It's not that Cervidil's got no problems, but there's a lot of baggage associated, including maternal death and fetal death with Cytotec, which might make it a better choice to choose another medication.
Well, you know the reason they don't use Cervidil instead of Cytotec is Cervidil is $200.
Money.
Cytotec is 25 cents.
And Cytotec,
I can tell you that's the reason why it's used.
Wow.
That's the reason. And Cytotec is and misoprostol. It's the same drug because I've had doctors, moms say, I don't want Cytotec. Oh, we don't have that. We have misoprostol. It's the same drug. Or we have miso. I don't want Cytotec. Okay, we have miso. It's as if it's a different thing.
Right.
It's the same drug. It is not approved by the FDA to be used in pregnant bodies.
Right.
So it's an ulcer medication being used off-label.
Right. And that's what I teach my nursing students because that's what my pharmacology book says.
yeah, we're definitely using it off-label.
Oh yeah.
Ask a question.
I have seen it be very helpful when a mom is hemorrhaging and it's inserted anally after the birth.
Yeah.
And I've seen it be very helpful then, but there's no
Right.
baby in the body anymore. And it's
Right.
about clamping that uterus down so the mommy doesn't bleed out.
Right.
And, that's a different thing.
It's also very helpful in abortion care.
Mhm.
Actually, I believe it's an active agent in RU 486.
Huh. So I have a question, going back to that cost analysis and the reason why it's being used.
Yep.
If I'm offered the one that's not good, can I ask for, no, but do you have this? Is that like a thing?
It
Yes.
depends on the hospital that you're in. If you're in Highland, they will, Highland, I've
Yeah.
had great experiences working with the midwives at Highland, just so much respect coming from them. And then, you go to UCSF and they're like, this is all we have. That's all we got.
Which is not true. I mean,
So untrue, right?
That's
you
what
can
they
always-
tell-
You heard it here, folks.
That's what they tell.
That can't be true. That can't be.
Sounds
in a-
like
in a learning
institutional
institution?
racism.
No.
It does. It
See,
sounds
that's good
like
to know.
there's institutional
Those that
racism
should be
based on
growing.
economics.
Yeah,
Wow. Yeah.
yeah.
they
Yeah,
just don't
thank
want
you
to
for
spend
that.
Money
Know
on
that.
you. That's what it is.
Can you say the bad medicine again, slowly and loudly?
Or
Miso
spell it out.
Misoprostol, MISOPROSTAL. Yeah.
Well,
Yeah, well,
well,
And the other
PRO?
names and the other, the,
And
Cytotec.
Cytotec. CY.
CYTOEC.
okay. A good way to remember is I don't really want to drink the psycho soup, right? Cytotec and misoprostol. Okay.
Or miso,
Or
MISO.
miso, right.
Not the
Yeah,
healthy
That should be easy
broth,
to remember. Okay.
not the healthy bean broth, but
The nasty stuff, yeah.
I do want to just, point out that, like Lisa said, there is a huge difference between encouraging labor and inducing labor. So I want to make sure that we're very clear on that, because it's a wonderful thing to encourage labor. There are many herbs and different things that can be done. Samsara was saying, breast stimulation, or Lisa, someone, many encouraging intercourse. Having tea, walking, staying active. There are many things that should be done to help encourage your labor to come, but that's a natural process. That's like gently coaxing your body and your baby to try to get things ready. And that's completely different from, forcefully inducing your labor. So I just want to make that clear.
such an important point. Thank you for making that really important point. What I'm seeing is mamas being robbed of their last 2-3 weeks of pregnancy.
And babies, and babies.
And babies, yes. But
Yes.
mamas, I'm going to talk about mamas right now.
Yeah.
Because this is the time where you get to be in dreamy la la land. As First Nations people talk about, pregnant women should walk in beauty. That's the time those last few weeks. Yeah, you're heavy, and yeah, you would like this. This miracle is getting kind of old,
Yeah.
but just being able to be with it, and if it's a first baby, your life is going to radically change. Enjoy your life, have ceremony of releasing and accepting your new
Yeah.
beautiful role in the world, making love to your partner if you have a partner, being close together, because it's just two of you now, even though baby's in there, but still just the two of you now, and you all are going to do this beautiful transition and go into it with your heart open and with the courage that makes motherhood what it is. It's something that's so profound and respected until patriarchy started doing its thing.
Right.
It's such a beautiful time that women are just flipping out, and they're trying to make themselves go into labor, and they're looking up things on YouTube, trying to push themselves into this
Right.
process.
Yeah. There's an excellent study that's being conducted on using dates. 37
Yes.
weeks, 6 dates a day
Love it.
to
Wow.
make a labor shorter and happen more quickly. And how much more natural can that be?
Mm.
And if it works, it works. If it doesn't work, you still are getting a really good source of iron and fiber.
Yeah,
Mm,
dates are great. Dates are wonderful.
Dates are full of vitamins and minerals and enzymes.
Oh my God.
Yeah.
Liana eats a lot of dates.
Oh,
I
really?
just want to tell you guys that.
I do almost nightly, and I do
Oh, wow.
dates with cashew.
A lot of dates.
on,
Mm.
in
Yeah.
the
They're
evening. it's
yummy,
a
too.
dessert.
And it is Ramadan now, so
Yes.
dates
The
are
other
a
thing
thing.
is dates look like are shaped like the womb and they have a seed inside. I just put that in the chat, but it's true. And there are teas as well and herbs. But it's very important to be clear about how to use them as well.
Right.
And so for those moms that are listening, as we're in COVID, you have a resource right here. You have Samsara, Tora, Jennifer, can connect with Debbie. We put a resource together last year.
Lisa,
Lisa,
Mhm.
and even myself, but I encourage you to contact everybody else first, so that you can find out and get information, right? You don't have to be uninformed, and you can know that you are not alone with this, and you can also begin to work with someone to support you and advocate for you, whether you're going to have a doula, a midwife, or have someone that you choose, your husband, your partner, to work with you with your birth to make sure that your birth happens in the way that you plan. Not everything goes to plan, because babies are babies and births are births, but the intention would be for you to have a comfortable birth. Don't know if we can say easy, but at least for it to be as comfortable and easy as possible. And that starts with knowing who first of all, knowing the right questions to ask, right? What a healthy birth and pregnancy looks like. And then writing down your birth plan and then making sure there's somebody that can advocate, even if it's your nurse, like Tora. Could you talk about that though? Because I mean, Debbie asked were there things that we had missed. I think it's really important that people know how to advocate for themselves, and then what that means. What does that look like?
Yeah, I think this is a good segue into Tora's. I asked panelists what they wanted to talk about, and she said she wanted to talk about consent, which is one of the biggest things in all this. And before you go into it, Tora, I just wanted to say, what I told a lot of my brilliant friends when they were pregnant and you're faced with that fear of like, oh my God, my body's splitting in half and letting out another being, is this notion of, this is evolution, right? Like it's way bigger than you, right? Like it's going to move forward in its own time and its own way. So learn to trust it and claim the power in that and take your place, right? Versus this, I think the way that it's been pushed for so many years now is that it's this strange thing that needs so much help and it's so delicate, and there's cases like that, but really it's
so
evolution.
It's so important for us to again talk when you're talking good talk about birth. You want to spread the good news. The gospel of birth is that the vast majority of healthy human females or folks that have female equipment, they can do this.
Yeah.
They can do this.
Yeah, and to claim that power is what gives you, Tora, take it away, consent.
Consent, yes. Okay, in my job, consent is really important. And that's one of the things I encourage, especially as a doula, because I have a different relationship with my clients, that they learn as much about birth and themselves as possible. Sometimes therapy is an excellent adjunct to education. When I get a patient in labor, I always make it a point to introduce myself and tell them that I am there to help them achieve the birth they want. And there's so much fear in birth. So one of the things that helps people have control And it depends on what stage of labor they're in. If they're just water broke and they just came in because, you know, their doctor told them to or whatever, then you can have these rational conversations with them. But if they're in the midst of labor, you don't have a conversation about, you know, we need to do this and this and this. No, we need to sign these papers. No, that can wait. Just this past 2 weeks, I've had 2 patients come in, have 3-hour labor. So all I was doing was holding their space for them to get this baby out. And they did beautifully. And one even said, I'm really scared. I'm like, it's okay. It's okay to be scared because this is scary. It's powerful. But you got this. You got this. You're doing it. Look at you. You're amazing. So encouragement and is so important. And I also preface, especially when we're talking about medications, especially for the baby, I always preface it by saying you have the right to refuse anything. And then we talk about the medication, like they're scared of fentanyl because of fentanyl in the streets and what they're hearing out there. Right. And I'm like, well, it's a very commonly used drug in labor and delivery. We've been using it for the 27 years I've been a nurse. So, and it is valid to have concerns about it. It's a short-acting narcotic, and it won't preclude you from getting an epidural if that's what you want to have. But sometimes I've seen it work where you just need 1 dose of pain medication to help you try to get through this part of labor, and then you have a baby. I've seen it happen. So education is key to consent. And when like just 2 weeks ago, I had a patient, the doctor, it was her second baby. The doctor checked her. One, I hate that they check on them so often. That makes me crazy. But the other thing is, so he wanted to break the patient's bag of water. And I said, I got the amni hook, but I said, you can't have this until you consent the patient for this. And he was really taken aback by that. You know, you don't say, I'm going to check you or I'm going to break your water. No, that's not consent. That's a command.
Yeah.
So,
Right.
So we need to train our nurses and physicians and midwives, because I've seen midwives do it too. Say, instead of saying, I want to do this, or I want you to do this, is it okay if I do this? And this is why I want to do this. And then the patient has to say yes. And if they hesitate at all, they're like, I'll say, well, maybe you and your partner want to talk about it. And then we'll leave the room so they can talk about it. And I'll come back and say, have you decided what you want to do? And if they're still unsure, that's a no. Right?
Right. Absolutely.
Right. So that is what we need to make the attitude in all birth situations, unless it is a true emergency. And those are rare, but they do happen.
Right.
And even then, as we're running to the OR, I am talking to the patient because they're often left out in the equation. When you're having a true emergency and there's a reason you need to get, your baby's heart rate has been down in the 60s for 7 minutes, and we need to do something to get this baby out. I'm still talking to the patient. Okay, your baby's heart rate is down. Everybody is getting you to the OR. We may have to do a C-section, but you're going to be okay. It's going to be okay. We're going to do everything we can to make this okay for you. So consent involves education, explanation, and heeding what the patient wants.
Preach. Heeding what the patient wants.
Right. And if they don't want it, or if they're not sure they don't want it, then they don't need it. Because if breaking the bag of water for the doctor is going to cut off an hour of their time or add 20 hours to their time, and then they're like, oh, their fever is 102. So now they get antibiotics that they didn't need before. They get, IV Tylenol. They get blood draws for lactic acid and blood cultures, because we caused that problem, right? We won't even talk about COVID patients.
Oh, Lord.
How they're, so isolated. So if I get a COVID patient, and I've had several in labor, if I'm going to put all that crap on to go in the room, all that PPE, which is hot and sweaty and terrible, I want to be able to stay in the room and talk to the patient, especially if they're by themselves.
Yes.
And sometimes that's the case. So that's what consent should be for laboring people.
And it's good for us as community members of people that will be going in to be giving birth, as moms who are going in to be giving birth, to really push this out in our community, right? Like, what does it mean through the whole process, through pregnancy and birth? What does it mean to have people that should be looking out for your well-being actually do that, right? Sometimes they need to be coaxed to do that, right? And
Yes.
and you take that agency to be able and say, wait, hold up. What was that quote you said, Jennifer? It's I thought it was brilliant, right? Because it causes the opposite energy from coming at it as, what are the alternatives? It causes the brain to kind of shift and be like, let me think about this. What is the alternative, right? That's a brilliant way of advocating for self. But to know that if you feel, okay, so instinct is such a key part of giving birth, right? You have to be tuned in, you have to be able to know what your body's feeling. And if you're feeling a certain way about something, to be able to listen to that and communicate it to the people and say, wait, this somehow, I'm not vibing with this, or give me a minute to really understand it, all those different parts. Yeah.
Right. Yeah, Tora's points are excellent. I mean, consent has to involve explanation and education. You cannot give consent to something that has never been explained to you, that you don't know what it is. And many times we just say, oh, we want to AROM you. And that's another thing. We'll say it in like medical jargon, or we want to, whatever. That doesn't mean you understand it. So you must understand fully what it is that they are suggesting, why they are suggesting it, what are the risk benefits alternatives, and then you can give a truly informed consent for that.
Right. Yes. So that's when we come to the acronym of BRAIN. BRAIN is a tool that doulas use, and I've seen it more and more in L&D, to make informed choices. And BRAIN stands for benefits. So what are the benefits of making this decision? Risks, what are the risks involved? Alternatives, are there any alternatives? I is intuition. What does my body or my psyche or my spirit or my gut say to me to do? And an N is nothing. What if we do nothing? Or wait it out? So that should be posted on the wall in the room, right? We should have those on, we should do some needlework and put those up so that patients know that they can ask. So if I had a patient, 5th baby, came in 8-9 centimeters, and they discovered the baby is breech. 5th baby. So they want to do a C-section. So with BRAIN, can we give her the option of delivering this baby, which is probably going to come flying out breech? And luckily for her, on the move to the OR, the baby did come out. Yes, right. But she should have had those options instead of having an emergency cesarean section for her 5th and at this point last baby, the last baby that she wanted to have, because she wanted a tubal ligation after this. What? So you're gonna section, and it was like a 38-week baby, and she had already had like 8 and 9 pound babies.
Oh, wow. That baby
Yeah.
was about to just slap. Yeah. That's
Right,
Yeah.
exactly. So, I mean, if that is not a perfect example of somebody you want to deliver vaginally breech, I
Yeah.
don't know what is.
Yeah.
And not having the understanding that when you've had a few little kiddos, a breach could be happening anytime, right? That could
Right.
be the baby's got room to do all kinds of gymnastics
Right.
because of the siblings that have come through before them, right?
Possible, yes.
Right, made room.
Yeah. One of my best deliveries ever was I had a patient had a vaginal birth, 2 C-sections, and her fourth baby was 32 weeks but breech. And so they were scheduling a C-section for her. And she contracted and she had a baby vaginal breech.
Wow.
Be back after 2 sections.
Wow.
The patient was so happy.
Absolutely.
I mean, it wasn't planned that way, I assure you. But it just happened.
Mm-hmm.
And I had a provider who was willing to help her have that because the baby was coming out.
Exactly.
So, yeah.
Yeah.
By the time we get to the OR, what's the point? Yeah.
Yeah.
I have a question.
Yes.
And this is, I'm trying to pull back when Ayana was trying to, pull out consent. And so you find yourself in a situation, you're giving birth, you're in a hospital setting. You have people you love around you and something gets proposed and you're not cool with it, right? Like for whatever reason, you're not.
Can I check your cervix?
Okay.
That's a perfect example that happens all the time.
Okay. Now, I'm somewhat giving birth, right? I'm not all the way at the end, but I'm in the process. I'm in the hospital. But so I state in a mild mannered way, no, thanks, right? And it keeps being pushed, right?
That does happen.
Mm-hmm.
So I have several questions. One is sometimes because I've been douling at a hospital that one of y'all here work at, where I literally wanted to kill this nurse, right? So my question is, can you ask for a change in nurse? Like what other modes? Okay, can you guys talk a little bit about this?
Absolutely.
Yes, you can. You can ask for a change of provider also.
Yes.
Yes.
Okay. Because that's key for us to know. Oftentimes it doesn't seem that way. It seems like there's shifts,
Mm-hmm.
and those shifts are very set in stone and you're sort of at the whims of this stuff. So that's good to know.
Right.
Yeah, you can and you should. Sometimes there's just like a personality clash. It's just not mixing. Someone has felt offended or not listened to, and there needs to be a switch.
Right.
Frankly,
Absolutely.
Yeah.
Absolutely. You can ask to speak to who's the head nurse on
The charge nurse. Yeah.
Charge nurse, and bring it to that person's attention.
Right.
I have had clients ask for a change and be told that they could not be due to staffing concerns, and that's horrible. And I don't know how much I believe it, but I just have to say. But the point is to ask. If you don't ask,
Right. If you don't ask, a closed mouth doesn't get fed.
That's right. That's right.
Yeah.
Yeah.
I feel like there's more to be said about.
But that was a really good question. Thank you.
Mm-hmm.
Yeah, because I can tell you I've only been fired by a patient once.
Because you're wonderful.
All right.
I am wonderful.
In how many years of work? Yeah.
25 in L&D. Yeah. But they just didn't have any sense of humor. Because the question they asked me was,
that's funny.
When is it too late for an epidural? And I said, once the baby is out.
I think
that's
funny.
Which is true.
Wow.
Right? It's true. You can get an epidural when you're pushing.
Right.
If you really want one.
I wonder how this person took it. I mean, I don't.
Obviously, they were offended.
Right. They were not in a joking mood that day.
They were not.
And she wasn't even in real active labor.
Oh, wow.
Yeah.
That's a scared person.
Okay,
right
sweetie.
there.
Yeah.
That mama was scared.
We would have been a good match.
Yeah.
Yeah.
But you know, most of the time my patients love me.
Mhm.
So
Yeah, I would, yeah.
yeah. And I
Um,
love them. And especially during COVID, I think that I've had to give them more love,
Mhm.
not being able to see facial expressions and with the masks and the isolation, because you know, just one person in the room for
And
most of the
doulas
year.
not being allowed in, may I
Right,
complain
right.
about that? So
Yeah.
Let
yeah,
me just say, Highland, we have welcomed back our doula, so you can have a support person and
Right.
a
We at
licensed
Outer Banks, we
trained
now
doula.
have 2 people now.
Okay,
We
good,
have 2
yeah,
people.
because
Yes.
a
So
doula is
exciting.
not an extra person, that is a part of your
Right.
birth team.
Yes.
Like,
right,
no,
right.
Yeah.
I would love you to, put that up on a billboard. You
Yeah.
know?
So on this consent tip, I think it's really important we hit on birth plans, because for me, let me tell you one of the reasons. I mean, I was almost killed by doctors, right? Pre-birth, pre-pregnancy, so I've had several experiences where I was like, oh snap, okay, there must be some karmic stuff with hospitals and me,
Right.
right? So,
Probably.
but my, you know, going into a hospital to give birth and being at the whims of everything that can happen, right? Causes, I don't know how to say it. You have to be extremely strong
Yeah.
and ready to battle if
Right.
you're going to go against any grain, right? And I didn't want to have to battle while I was giving birth.
And you
No,
shouldn't
I
have
felt
to.
like that's
Right.
not the
Worst
time for me.
time.
Right.
And one of the things you can sort of shore up that end is by having a birth plan,
Mhm.
right? I think it's key that we talk about that. Samsara, you have a book that walks people through it, right? And I think that's key. But talk about the importance of birth plans and the steps you want to take to make sure that the birth plans is going to be listened to when you finally arrive.
Well, I support my clients in having control over what they have control over. They don't have control over the hospital really, although they have lots of rights in the hospital that need help to be asserted, need help to have those things carried forth. The birth plan, one of the most important things about the birth plan is that it educates the client about what all their pros and cons
Right.
are, and it gives them the beginnings of informed consent.
Mhm.
Because the way things are kind of given to them by their doctors, they're not told the whole story. And they think, well, that's just how you have a baby. You go, you get an epidural, or you go, you get induced. That's how you have a baby. And because in our culture, we're not seeing birth around us, we're not living in communities where people have a whole bunch of access to pregnant people really anymore. I mean, I grew up Catholic in Brooklyn. Every other lady was pregnant around me my whole childhood. That's not happening the same way. And there were lots of babies, lots of kids. Those kids saw their siblings get born. Lots of the babies were still being born at home in the 60s in New York. So we're not having that world right now. So people are they're trusting, they're giving too much power away to the medical people with regard to this natural event in their bodies because they don't know about it. And it is very sad, So it is about getting with folks. And this is the thing too, intergenerationally, we have to look at our trauma around birth. We have to look at what we say to our sons and daughters about birth because they remember it forever. Right? And before they even get pregnant, before they even get into the hospital, because it is all about prevention. Then when you are a pregnant person and you're either working with your partner or working with a doula or any support person that's helping you write your birth plan, after you have all the information, you're going to create, I suggest a 2-page document. One is for mama's choices and one is for baby's choices, because 2 different staff look at that piece of paper. Sometimes doctors want to see everything, so they hand them 2 pieces of paper and they can read everything, and that's fine. But the pediatric staff has been very enchanted to have a birth plan to read. They're like, "Oh, this is for us." And it's like very nice for what the families might like. And then when I first started being a doula, there was no respect to the birth plan whatsoever. Like, and one of the clients that I first started working with, and wrote a birth plan with, the doctor came in the room, this is the birth plan. This is the garbage. This is what the doctor did in front of us.
No,
Into the garbage.
no.
It floated like a leaf into the garbage. And he said, we'll have no more of that.
Wow.
That's what he said. To the
I would have cut him.
Right, right. It's time to fight.
They don't do that.
Yes.
Yeah.
Wow.
And we were like, okay.
Wow.
So they're not so like that anymore.
They can be, though.
And the
But
good
they're not as
staff,
overt.
right. The
Can
good
I just,
staff will come in and read your plan, and they will ask you questions, respectful questions. And that's how you know, you can have an idea that you have your team is solid.
Right.
And they'll ask you questions and clarify what you mean by what's on the birth plan.
Right.
And then some people just give it a cursory look and go, oh, well, thank you, and post it on the wall where nobody can see it. And then your doula will take it and stick it on the monitor so that it's sticking right there off the monitor.
Right, exactly.
But, so you're looking for all these signs from before the labor even really gets going in the hospital, where, what work do you have to do and how guarded you have to be.
Right.
All of that guarding has to be done by the support people in the room, by the doula, the partner, auntie, grandma, who's ever in the room. Devoted nurses will do it too, because the pregnant person has to stay in la la land.
Right.
The pregnant person needs to be in oxytocin-induced bliss, talking to Jesus and her ancestors and the angels,
Right.
and she needs to stay there because that's helping her have that baby.
Right.
If she gets fearful and she's trying to guard herself,
Yeah.
it's gonna affect her scenario of labor.
Right, exactly. The only thing I would add is that if you can have a one-page birth plan, just like a resume, if you can put everything on one page, people are much more likely to look at it.
Absolutely.
Yeah.
yeah. See other tactics like, make sure you have several copies, make sure
Right.
that everyone in charge has it, make
Right.
sure that you
You
always
pass
keep
it out.
one close to you.
Pass it out.
And
Yeah.
Right.
Everybody who walks in the room, pass one out.
Right.
a good thing to do too is to discuss it with your doctor when you're still doing your prenatal appointments.
Right.
Check out anything there. And
Yeah.
then sometimes it can be scanned into your file. It depends on
Oh,
the
yeah.
hospital, so that's
Yeah.
helpful.
We
But a
automatically
doula,
scan it in.
there you go.
Right.
And a doula always will carry 3-4 copies of it because it magically could get lost, or in between shift changes, it gets filed under somebody else.
Right.
Things can happen.
Right.
And
Right.
it's there, as Tora says, it's hi, welcome, here's.
Right. Right.
Exactly.
Yeah. I
Yeah.
gave birth in 1998, and I can tell you that every single hospital tour that I did, I would ask them, so you guys have, because that was a way of me to gauge, like, how are you about it? Do you have a birth plan? And they would look at me and everybody's eyes would roll up. All the nurses, everyone,
sure.
like, oh, she's one of those. So this was 1998. So things have changed quite a bit.
They have.
Yeah. But I would like to
I had
know.
a baby in 1988 too. Yeah. So yeah, things have improved a lot.
A lot, right, a
But
lot.
there are
Thank
still
God.
people who are going to roll their eyes. I can tell you that.
Yes. Yeah. We still have a lot of work to do.
Right.
Yeah, we do.
But people who read it and try to do what they can to facilitate you,
Right.
those are the people that when you fill out that survey, when you go home and you talk about, oh, Nurse Kathy was really helpful and helped me achieve the kind of birth that I wanted. She read my birth plan. She was respectful. Please point those things out, because the
Yes.
administration is looking at that.
Right. Sorry.
That's a good point. I want to watch myself about getting stuck in the negative around hospital folk. We definitely want to lift up those who are giving that beautiful care, and send letters and have that be in their files, so when promotions and whatever come around, that they can be considered. We do want to thank them for their efforts.
Exactly. And so then when they get in trouble for advocating for their patients, not that has ever happened, you know, I can pull that up and say, oh yeah, but
Mhm.
98% of patients love
Mhm.
me. And this is what they have to say about it.
Yeah.
Neener.
Yeah.
Good for you.
So I want to thank you guys for a beautiful panel. And I also want to point to the pace. You know, I love this pace versus this. And I know people look at 2-hour, you know, webinars and they're like, I'm not registering for that. But these go for a long time. They get put up on pages. People can tune in on their own. And I like the ease with which we talk. So I thank you guys for that. I want to tell you guys how much I really honor the work that you do, right? And you too, Mama Yana, because I know,
Oh yes.
I know, which is why when I heard the story about the person who, you know, popped your bag, that was shocking to me. I know the work you do, the healing work that you do on many, many levels. So in saying that, I would like you guys to talk about what you represent, because you guys represent so much, right? All of you, right? I want you to talk about Moms to Moms, Tora. I want you to talk about Anthem program, the pilot program, which is so key. And I love this notion of like, you know, pitting the insurance people against the hospitals for like, what is actually something that is going to cost less if you like, forget about racism and all the crazy stuff and the women birthing, right? But just what is going to be cost effective? Let's even come at it from that angle, right? and have doulas come into the picture as a regular piece of things. And, you know, beloved Black Birth Center, which to me is like one of the biggest, because, you know, to have women pivot to home births is one thing, but to actually have an institution that works at also doing that, where Black women are in charge, right? That's amazing to me. So can we start with that? Jennifer, I know you said you had to hop off at some point, so let's start with you.
Oh, sure. And I want to say thank you, Deb and Mama Ayana and Healthy Black Families for hosting this and for having us. This has been wonderful. And, you know, if I can speak for my other esteemed panelists, like this has been very enjoyable. So thank you for giving us the platform.
Yes.
And thank you for all you guys who are tuning in. So Beloved Birth Black Centering is group prenatal care that is given by, for, and with Black people. And I think to answer what it is, first you have to understand why it is. So basically, what we want is for all women to have wonderful, healthy pregnancies, births, healthy, beautiful babies, of course. But in response, direct response to the crisis in Black maternal and infant health right now, and the disparities that we've all heard about, and the fact that Black moms and babies die at a rate that is disproportionately higher to other women. Our response to that was this radical intervention, which is group prenatal care for, by, and with Black people. And what we wanted to show is that we are in a crisis, but there's nothing wrong with Black women or Black bodies. Black people are strong, resilient, we're perfectly capable of having healthy pregnancies and healthy babies. The answer to the crisis is kind of changing the environment and the way in which we are giving care.
Right.
And so the program is specifically designed to address the problem of racism in healthcare and try to combat the health disparities. So you get an all Black care team. It's led by one of our Black midwives, Jaisha Wren, who's the program director. Black lactation consultants. There's a Black family advocate member. We do it in partnership with the Alameda County Public Health Department. And so one of their amazing family advocates is part of it. We have wraparound social support services.
What's her name? Her name is Danielle.
Danielle Davis.
Yeah, I want to shout her out because I saw her on a webinar. Yeah,
absolutely. So you get to benefit from being in a group prenatal care model with about 10 other Black women who are, set to give birth around the same, due date time as you. There's, culturally congruent exercise and dance and, talking about spirituality and what it means to move as a Black person in this world, especially right now with all that's going on right now, just in current events. It's difficult to be a Black person right now and have to have all this like extra stress on top of us. And it gives us a forum to even just talk about that and ways of decreasing stress. We have partnered with Nourish. Tora, were you a part of Nourish?
Yes, I want her to talk about the Nourish program.
Yes, because we partner with that amazing program and provide postpartum meals for these moms. They're getting all kind of services. So it is absolutely, it's kind of just, we call it like the gold package of prenatal and postpartum care right now. And it's offered at Highland, and I'll put some of the information in the chat for people. If
Dope, thank you. And for those of you who have registered, we'll be sending out the information. There's an amazing informational infographic that Samsara put together around inductions, around healthy pregnancies. There's the whole, consent brain methodology link that we'll be sending out to you guys. So yeah. Tora, you want to take it away with the Nourish?
Yes. I have been with it's Mothers for Mothers Postpartum Justice.
Right.
And it is an organization that was started after a class at UC Berkeley, where we had different speakers. We had a midwife, we had a doula, we had acupuncturists, we had a nutritionist speak to the class.
Researchers.
There were researchers too, yes. Because
Ayana and I came to that one.
Right, yes. We were looking at how there was nobody advocating for mothers or birthing people after the baby was born. We have a lot of things to help them have a baby or have labor, but there's nobody to help them in postpartum. Traditionally, of course, we always had the village to help new moms. So we basically started a program. One of the things we do is we provide meals for postpartum Black mothers for 6 weeks after the baby is born, and it's free of charge for them. So we collect money. We've had donations, we've had grants that have given us enough money that we can provide meals for the first 6 weeks for, I think we provide 5 meals a week, 5 sets of meals. So it's like 10 servings of food plus a produce and box for new moms and families. And they just have to be enrolled in Roots or Black Centering or is it One Love? One Love, I think, because we also have spread into San Francisco too. So moms who deliver at San Francisco General.
That's amazing.
Meals too.
It's amazing. And then these are not just regular meals too. I just want to say, like,
the restaurant meals, they're meals from restaurants we partner with. One that I can think of right now is Tenney East. And they provide excellent food for these new moms.
Yeah.
And it's a partnership that has worked out. I think we've started in April of last year, and we've provided over 1,200 meals.
Yes.
For new moms. Yes.
That's amazing.
Yes, we much respect to, I feel like we need to shout out Marilyn Wong, Dr.
Marilyn Wong
is
our executive director. I'm the treasurer.
Yeah.
Wow.
Let's also say that these are healthy meals.
Yeah.
So
right. That's it.
Talk about Nourish, but these are really
so Nourish is the part of the program that provides these meals.
Wow.
Right. Which
Samsara.
I put the link on the chat, and also our Instagram page is Maternal Postpartum Justice, MPJ. So go check us out.
Yes.
That is amazing.
Yeah.
Samsara, Oakland Better Birth
Yes.
Foundation, and the Anthem Pivot.
Well, yes, I'm the executive director of the Oakland Better Foundation here in beautiful Oakland, California. And I was very happy to have the folks at Anthem Blue Cross reach out to us and ask to partner for a pilot program. We have the ability to serve 50 families under this program. And the program will pay for the doulas. So the doulas will actually, get some money in a reasonable amount. And we can have an opportunity to prove to the big institution how we can save them some money.
Mm-hmm.
And the hope there would be, because it's not only us providing services, but also collecting data on how our clients do with doula care. My doulas are very, very excited to get started on this. We're just starting to get our first couple of recommendations that have come in. They're very excited to serve the community. And if there are doulas out there who would like to work with us, please feel free to contact me. You can go to our website, oaklandbetterbirthfoundation.com. That's a great way to reach me if you want to reach me for any old thing. Oakland Better Birth Foundation provides, we have a commitment to providing doula care for any family, regardless of income, period, dot. We have worked on a sliding scale from there to nothing. So if you come to us and you want to have doula support, we can get that for you. We also provide childbirth education, lactation education. Everything that we do is on a deep sliding scale. We do training that is not as flexible because I'm training through another organization, but we will help you raise the money to pay for doula, the initial round of doula training. We have as I mentioned, the Facebook page. We also have a channel on YouTube, Better Birth TV. So you can pop in there and there's all kinds of wonderful information. And I'm building the channel, so there's more and more good stuff that's being added every day. One of our childbirth education classes is there in full for folks to look at and decide whether they want to come and take the full class in person and ask questions. We also have a beautiful Spanish language childbirth ed class available that's on the YouTube channel and being offered live as well. All of our classes are on Zoom now because the whole world's on Zoom now. But we also give references to midwifery care and birth center care. I'm on the board for Pacifica Family Maternity Center. I'm on their family fund board. So we help raise money through the board and we help to give grants to families to be able to birth at Pacifica.
So much incredible work. Thank you so much. Yeah, so this concludes our spectacular, webinar. Ayana, do you want to say something about Healthy Black Families?
Thank you. I was reading the chat. Well, Healthy Black Families is a Black woman-led organization whose roots come out of Black infant health, Berkeley Black infant health. Our founder and leader is Dr. Vicki Alexander, a former head of maternal child infant care for the city of Berkeley. And also she was a director in that area at Highland Hospital. She's a former OB/GYN. So we're rooted in birth and birth equity. But we also have multiple programs. As Debbie said, we have Telling Our Stories, and her next Telling Our Stories, and she'll probably talk about, is coming up next month. And then we also have Thirsty for Change, which is our sugar sweetened beverage, nutrition education, water promotion program funded through Healthy Berkeley. We also work with Roots with their sugar sweetened beverage program funded by the Oakland Soda Tax. And we have a nutrition education program with them. And we have Sisters Together Empowering Peers, which is our motherhood circles, empowerment, advocacy, and education. We had some of our, and leadership. excuse me, promotion. We have some of our step leaders that came through today. I saw Anika, Jemiah, Jackie, Ryan were on here. Thank you all for coming. Love and hugs to all of the step leaders and the work that you do. These sisters most of them have gone through Black Infant Health. And I have to just say that it's really, Black Infant Health is an incredibly important space for our young mothers to go through and receive
Yes.
birth education and resources. And many of our participants come through Black Infant Health. Also, we have our Right to Stay survey, and I'm going to hopefully be able to get a link in the chat really quickly to, if you haven't taken it, we want you to take it, especially if you are a former Berkeley resident or a current Berkeley resident or unhoused, where we are working on creating an affordable housing preference policy with specific focus on the right to stay and right to return and right to own for people of African descent, Black, African, New African people in Berkeley. So I'll put that in the chat. If not, you can email me, and I'll put my email right now for any information that you might need, and I'll put my phone number in the chat as well. Sisters Together Empowering Peers, if you are a mother, a grandmother, or a caregiver, young children 0 to 5, or you're pregnant, we really invite you to join our motherhood circles. If you're in East Oakland, the Roots Motherhood Circle is available to you, and we just started our Healthy Living 101, which is a deep dive into nutrition and health and well-being led by Rahima Nitoto that's happening. And I'll put her email in the chat for
Right.
you as well.
We're trying to
Thank
catch
you.
it before the pregnancy. See, we're like, let's shift this culture.
Exactly. And
Yeah.
it's really important to, I think, for us to support each other's work and spread the word about the work we're doing. So I encourage everyone to share this video off of Facebook Live, to talk about the information that you learned, to talk about the organizations that are present here and the women that are in leadership
Yes.
as well. I think it's important to acknowledge the work that you all are doing in leading the way, and along with just the fact that so much thought leadership and so much change in cultural shift comes from Black women.
Yes, and always has.
And
Mhm.
always has. That's a great
I'm
note
complete.
that to close it on. Much love and respect. I'm gonna run. I'm just gonna run the slideshow so people can see it a little bit more. And feel free to hop on anytime.
Thank you all so much.
Thank you so much.
Incredible.
Thank you. Thank you.
We're indebted, and you know you can call on
Yes.
us anytime. Anytime.
Thank you.
Thank you.
Thank you.
I gotta put my number in the chat. Where is it? Just talking. Mhm. Let's see. What else?
I can't get to what I need to get to on this screen.
Debbie,
Yes.
what I didn't say is thank you for all the hard work that you put into this.
Yes, Debbie, thank you.
Yes, and for your dedication and your
Yeah.
presence in this.
Thank
and
you, Debbie.
showing up so-
You are awesome.
You're
Yes.
awesome.
And your
I re-
facilitation, excellent, excellent.
Yes.
Thank
Yeah.
you.
Honored to be here.
We need to do this like every year.
Yes.
Yes.
So this is it's happening. Here's the second one, second year.
We need to do this like every month,
Right.
honestly, because
Yes.
folks there's a lot of struggle going on out there.
There is.
And I was gonna say, we actually did, this is third year, because the first year we did it in person. Remember Samsara?
That's right, that's right.
Yeah, we were at the.
Oh, that's right.
Yeah.
That's right. The
Where we talked
the
about
step-
unnecessary cesareans and safe and healthy birth practices.
That's right. That was wonderful. That was really wonderful.
Thank you, Deb.
Yes, ma'am. This is what I was trying to get up so that folks could get it.
Ah, there you go.
Yes. Oh, Friday.
Is it are you done recording now?
About to be. Yeah, I think so.
Yeah, it says recording. It's still live on Facebook. That's what it is.
Yes.
And I'm going to work tonight.
Nice.
Yes.
There will be some peaceful births in Berkeley tonight.
Yes, there will
Hopefully.
be. Yes, there will be.
Hopefully. Yeah. Or
Deb,
I
you
should
have
have
to
bragged
stop the
that-
live.
I should have bragged that Tora delivered one of my grandbabies.
oh yeah.
Yes, you
My
should have.
My God, I should have said that.
Oh my
I'm
God.
so
It was
sorry.
all cute too.
And he's even cuter now. That little
Oh, I can only imagine.
OM.
So sweet.
Yes.
Yes.
Yes. That pleased me so much.
I know. Well, you know, I know I've made it when one of our physicians asked me to be their nurse.
You know that's something.
Yeah. Yeah. Bella. Bella.
She says it's time to get off.
Oh,
All right,
let's go.
ladies.
Well,
Much
she's got
love.